Hello, everyone. Hello, and thank you for coming. My name is Dr. Orit Wimpfheimer. I'm Chief Medical Officer at Nano-X, and I'd like for the next 20 minutes to explore with you AI and digital tomosynthesis in the world of pulmonary nodule detection. Lung cancer screening. Where have we gotten to? Where did we start? Where are we today? And let's maybe spend the next 20 minutes of reimagining a future. The problem exists. Lung cancer is the leading cause of death worldwide. It accounts for 18% of all cancer deaths, and the numbers just keep climbing. By 2050, there'll be about almost 5 million new cases per year. That is a lot of people. It's the number one cancer. We have been working with lung cancer and lung cancer screening for a long time. Where have we gotten to? Why is there such a high mortality for lung cancer? Most of the time, it's because we're diagnosing it too late. There's often aggressive tumor biology, but even if there isn't, detecting it early is key. It's something we've been talking about for many, many years. Detecting lung cancer early is the key to decreasing the mortality associated with this disease process. In fact, we've been working on this for over 20 years now. The initial lung cancer screening trial began in 2002. That's 20 years of lung cancer screening efforts. And so low-dose lung cancer screening is now available in the population. The guidelines have been updated several times. So we know who we're supposed to be screening. Patients ages 50 to 80 with 20 pack year history. And this subgroup has been expanded over the years. They took off the requirement to continue smoking right now, certain pack years. They lowered the age. And different efforts have been made to widen the population for lung cancer screening. And why is that? It's because the numbers really don't show effectivity. Only about 1 in 5 patients, that's new data that just came out of JAMA. In 2024, only about 1 in 5 patients that are eligible in the high-risk population for lung cancer screening were actually getting their low-dose CT scan. And that's just the high-risk population. Only 4 to 5% of patients are getting yearly screenings that are eligible for it. So even those 1 in 5 that are getting a lung cancer screening initial study, very few of them are coming up for their follow-up. We're not being effective. And moreover, about 15% of lung cancers develop in patients that are not even in the high-risk category. So they're not even eligible for lung cancer screening. So while there's been a 25-year effort for lung cancer screening, we have been only limited effect in the medical community. We're just not getting the job done. Maybe we just need to reevaluate it. And the need is there. If you find lung cancer in its early stage, it's been proven in a lung cancer screening program, it's been proven that you have an 80% survival rate. So we all agree that we need to find these lung cancers early. We all need to agree that we need to have some sort of screening programs, but the lung cancer screening programs, as they're being performed today, are only having limited effect. I think maybe we need to consider reimagining. What can be done differently? How can we do it better? So we need to analyze, why is lung cancer screening not working? Why? Where are we going wrong? And there are a lot of papers that show that there's difficulty with awareness and doctors are not ordering them. But a big factor is accessibility and limited cost barrier. Not everyone has accessibility to a lung cancer screening program, ability or interest to search out for it and get their lung cancer screening exam. This is where we come in the world of digital tomosynthesis. Let's see what the data shows us. Can digital tomosynthesis make a dent in reimagining the world of pulmonary nodule detection and lung cancer screening? Just in October, in the LCAP study, Dr. Yankelevitz, who was the primary investigator in the initial lung cancer screening program, suggested that the data demonstrates that even chest X-rays themselves, without the need for our CT scan, have a 20% reduced mortality just if we use chest X-ray screening. That shows that we're not starting from scratch. Maybe chest X-rays were underutilized in the world of lung cancer screening. And why did he go in that direction? With the same problem I'm mentioning now. The accessibility and availability for CT scan for lung cancer screening is more limited than people realize, and patients are not getting it. Whereas chest x-rays are ubiquitous, they're cheap, they're low dose, and they're easy to obtain. CT scan does have utility and does decrease mortality, but the benefit of chest x-ray alone is valid. What if we can make that chest x-ray a better opportunity? Improving pulmonary nodule detection on the chest x-ray-like device to increase pulmonary nodule detection without having to run to a CT scan. Can we reimagine? And now there are plenty of studies that are actually looking into that exact situation. This is a meta-analysis of 16 different studies in the world of digital tomosynthesis. Overall, evaluating over 2,000 pulmonary nodules in many different studies across the world, which demonstrates that digital tomosynthesis, which is essentially taking coronal images, X-ray images through the chest, approximately 60 or so images through the chest. So instead of having just a 2D flat image, you now have many images across the chest, increases the sensitivity of pulmonary nodule detection to make it a sensitivity of approximately 85%, whereas the chest X-ray sensitivity hovers around 47%. That's a considerable increased yield in identifying pulmonary nodules using a digital tomosynthesis device, allowing for improved pulmonary nodule detection on a much simpler, lower radiation device than we have on CT scan. Every single study of the 16 showed considerable benefit. In a study performed in Italy, 1,900 participants went into lung cancer screening using digital tomosynthesis. Exactly what we're speaking about now was published in the Journal of Thoracic Oncology, and it shows that digital tomosynthesis detected the clinically relevant nodules, which are nodules of 5 millimeters and above, which is really comparable to the detection rate of the CT scan. And when you evaluate the pulmonary nodules as suspicious versus non-suspicious, there was an 86% concordance rate with a CT scan. The argument here is that digital tomosynthesis can do the work of a CT scan. We don't need to go to a CT scan in order to get pulmonary nodule detection. And there's a much, much lower radiation dose exposure using digital tomosynthesis. It's a much cheaper modality. It could potentially be much more ubiquitous and available, less scary for patients. Maybe changing the paradigm is something that should be considered. An additional study in the Journal of Clinical Oncology looked at using digital tomosynthesis in the world of lung cancer screening as alternate with the regular CT scan. Maybe we don't need a CT scan every year. Maybe we could take a low-dose CT scan one year and alternate it with digital tomosynthesis of the next year, and creating a paradigm where we don't need the higher cost and higher radiation dose every year, and potentially able to get patients in for their yearly screenings and not lose them after the first year with an initial single state CT scan to evaluate that patient. It was a 5-year prospective trial, and they found 22 lung cancers, which correlated with a typical percentage of cancers identified in these lung cancer screening programs. And the argument is maybe there's a role for digital tomosynthesis, not just in the primary detection of lung nodules, but also in the dedicated screening programs, alternating with CT scans as we're used to today. Digital tomosynthesis has much better sensitivity and specificity compared to a regular X-ray. It is comparable to detection of lung cancers on low-dose CT scans, and it's shown to have an 86% concordance rate in lung cancer calcification of suspicious versus non-suspicious nodules for 5 millimeter and above nodules in the world of lung cancer. So I'd like to introduce to you the Nanox.ARC, which is our newly launched device with proprietary cold cathode tube technology that takes digital tomosynthesis images of both any part of the body. It's FDA approved for general use, but the discussion here is the world of lung cancer. So I'd like to focus the attention on the use case for evaluating the lungs using digital tomosynthesis. We did an evaluation of the current model versus traditional linear tomosynthesis back from the olden days, and showed that our technology has a 35% less motion than the original digital tomosynthesis devices. So it improved visualization And therefore, this proprietary new technology is something to seriously consider in this world. And what makes the machine so incredible? It's a very small footprint. It's a very lightweight device, easily deployed in many types of clinic situations. It provides images, tomographic images, but it's very user-friendly both for the radiographer and for the patient alike. They go in and out in a very simple manner. The electricity is just a typical plug and play into any electrical outlet, requiring only X-ray lead shielding and no CT lead shielding. It's easy to place in any clinic, pulmonology clinic, multi-specialty clinic, an imaging center. It's a really easy to use device. It's very low radiation. It's like getting a double chest X-ray rather than getting a CT scan, and it's about 80% less radiation dose than you'd have on a CT scan. So this has the potential to really change the world of chest imaging in general, and with the focus on pulmonary nodules. We can use it for general detection of pulmonary nodules, as was my first argument, but also incorporate it into the world of lung cancer screening to offer cheaper, lower dose alternate study rather than just having a CT scan every year. So let's go through some images, because I'm a radiologist and I work in the world of images. On the one side, on the left-hand side, you see a regular 2D radiograph. The nodule that you can see on the digital tomosynthesis is very clear once you slice through the chest, and not so easy to see, in fact, very difficult to see on chest X-ray. Most radiologists would not see it on the X-ray, and clearly easy to see on the digital tomosynthesis. Has real potential to find those nodules that we're all looking for. Here's another example, an image that has, on the left-hand side, a regular 2D X-ray. You cannot see that small nodule. And on the right-hand side, you see digital tomosynthesis slicing through the chest, front to back, and you see the small nodules circled in red. Much better to detect pulmonary nodules. Really has the opportunity to change pulmonary nodule detection in this world. Here's another example on the left-hand side of a 2D X-ray where you don't see a nodule. And here, as you slice through the chest front to back, you see the nodule along the cardiac silhouette. That was confirmed on a CT scan, performed follow-up. That's clearly a nodule on the CT scans, not able to be seen on X-ray, clearly seen on digital tomosynthesis, confirmed by CT scan. We have real opportunity here to change the paradigm for pulmonary nodule detection on a cheap, low-dose device. Here's another example on the left-hand side of a patient with clear disease in the right lower lobe and a pleural effusion, a pulmonary nodule that was totally hidden within a 2D X-ray and clearly visualized as you slice through the chest. Circled in red, you see a pulmonary nodule that pops out into your screen. You can see it now because you have the digital tomosynthesis. How can we incorporate artificial intelligence? Well, when you have a device that is not used ubiquitously, AI has the opportunity to afford that companion tool ability for the radiologist or any clinician to have that comfort level that we can help you find the nodules, we can show you where the nodules are so that you don't feel unsafe or unsecure with this new technology. And that's what we're developing at Nanox. Each device, as sold currently, is AI ready. All the devices can be visualized and controlled remotely, so we can always pay attention to all the device and the technology behind it, and also run our AI algorithms. It's available to read at the reading station, and ultimately it's to reduce the learning curve for radiologists and other clinicians who are going to be reading these studies to support them in the reading of pulmonary nodules. So here's an example of another patient. Again, a 2D X-ray in the left-hand side. On the right-hand side, you have the digital tomosynthesis. There's a nodule right here. Let's play that again so you can see it. I purposely didn't mark it in red because you can see that a radiologist may or may not feel comfortable detecting that nodule when they're not so familiar with the modality. But you can have AI, and this is an AI algorithm that we developed that will highlight for you in a bounding box where the nodule is, lending support and comfort to the reading physicians. Here is another example of a patient. On the left-hand side, a regular 2D X-ray, and on the right-hand side, another example of a tomography image. Here's a series on the patient. Here's the nodule that was detected. Here you go, right here. Wouldn't you like the AI to be able to allow you to visualize that? Just create that box for you and show you where the nodules are and allow you to feel comfort that you found those nodules. Again, this is a real opportunity to change the paradigm of pulmonary nodule detection. Here's another example of a patient on the chest X-ray. There's something there. It could be a nodule. It could be a consolidation that's dense. On the tomography image, you go back and forth. You get a much better sense of what this nodule look like, what its borders are. This is more obvious. You don't need the AI, but the AI confirms that there's a pulmonary nodule there, leaving you comfort to know that you found that nodule. One more example. Again, images are worth 1,000 words. Here's an example on the left-hand side of a patient with pleural effusions and consolidation at the lung bases. And if you look at the tomography images, there is a nodule, that could easily get missed because you're focusing on the pleural effusion and the consolidation. But if you have AI pointed out for you, there's a nodule here situated along the anterior aspect of the right mid-lung zone between the two ribs, so the AI gives you that added comfort of finding that pulmonary nodule. Here is confirmed on the CT scan that the patient had later that day. Now, the platform of AI, as we all know, no AI in the current world is going to be perfect. Every radiologist would love to have AI, but no AI should be exported to PACS unless the radiologist confirms that the AI findings are accurate. I'm a radiologist. I've seen lots of different AI products, and radiologists are key to approving or not approving the AI outcomes. So in this example, a patient that has a 5-millimeter nodule, the AI found the nodule. The radiologist or reading physician will have the ability to check, agree with the AI results, and then export them onto PACS. Only approved nodules, bounding boxes will be sent to PACS. That way the legal ramifications are not as difficult, and therefore nodules could also be followed up in subsequent years because everyone agreed on the nodules that are on the scan, and then the follow-up years we know which nodules we're tracking, and we know how to make sure that they haven't changed in size. But it's always a work in progress, as all artificial intelligence algorithms are, especially in the world of pulmonary nodule detection, because at the end of the day, the AI algorithm will find certain nodules, and we can agree with them, but it will also sometimes detect nodular densities that the radiologist feels are not nodules, but rather a vessel. And again, the radiologist will be able to reject those nodules and not send them off to PACS, and once they're happy with the results, they will export to PACS, and it'll be saved in the patient record. So ultimately, the take-home message is digital tomosynthesis, and in particular the Nanox.ARC, has a real opportunity to change the paradigm of pulmonary nodule detection, incidental detection, and also in the world of lung cancer screening. We can see pulmonary nodules increased by 30% over regular chest X-rays, incorporating digital tomosynthesis, which is a really easy to use device, very patient-friendly, very radiograph-friendly, is really something to consider when we're trying to tackle a disease process that 20 years of low-dose CT scans hasn't really managed to solve. Please come visit us at our booth. You can see a demo. You can see a lot more clinical cases. There are also additional use cases in the world of musculoskeletal imaging. So this machine is not just a one use case device. Musculoskeletal imaging is a whole other world that we can show you at our booth, and the benefit of using digital tomosynthesis. Thank you so much.